Yeah, that's a good question. The new golden era, maybe yes, maybe no. And it's both a little provocative title, of course. And we were happy to show the use of the Heliostar RF balloon. And the Heliostar RF balloon is a 28 millimeter balloon. It uses irrigated RF energy, unipolar 15 watts, and one application lasts 1 minute. And we did treat with this PVI approach a 59-year-old female patient, and she was paroxysmal AF, CHEST-VASc score of 1, error score 2 to 3, and as I said, the Heliostar balloon, 28 millimeter diameter and irrigated RF. And I was actually struggling a little bit with the left inferior pulmonary vein, if I recall it correctly, and which is unlike to the cry balloon, it does not act as a cry balloon. So you really need to get proper contact with a full circumference to all veins in order to get proper isolation. But you can also obtain, as you can see here, single shot isolation. And I think there's a typo. The right inferior vein was also ablated with a single application. The left inferior vein took us 3 applications in order to get to isolate it. But in the end, all veins were isolated during the case. And the post-ablation course, again, we did see the patient in our outpatient clinic ourselves. And in Germany, typically we keep the patients. And this is something which is interesting compared to UK and US. You are living in the same day discharge reality. We may enter this stage maybe also soon in Germany, but at this point in time, she was discharged after 2 nights, and we performed an endoscopy because there was some temperature rises in the esophagus as well, but we could not demonstrate any thermal damage. So that was good news on this side. And again, we have seen her after 3 months and after 6 months, and there was no AF recurrence, there was no documented recurrence, and the patient felt fine. There was sinus rhythm in ECGs documented. However, it was not that vigorous with regards to daily transmission or constant smartwatch surveillance. So it was not a study patient, it was a clinical routine patient. And therefore, we had those 2, let's say, time points of follow-up. We stopped all antiarrhythmic drugs right after. No, we did not stop. There was no antiarrhythmic drug involved in this patient. We stopped the DOAC because this lady had just this CHEST-VASc score of 1. And the patient was also happy, and we were also happy. And they're looking forward to the 1-year follow-up in that, nice lady.
Okay, wonderful case, Julian. Obviously, we've all been very successful. We're going to have some failures next year because our results are all too good. But tell me about the right inferior pulmonary vein. Do you think that some veins are more important than others? Because my impression is when I take someone back for a redo procedure and that's the only vein that's reconnected, I sometimes feel a bit gloomy about the outcome. Do you think that's an important vein?
First of all, I think we need to wait for the 12 months outcome. Maybe the picture will be a little different. So it's a very short-term follow-up. But with regard to the importance of each vein, I'm not too sure. I mean, we believed many years back that the right inferior vein may not be that important. Still, we all have seen also malignant right inferior pulmonary veins. So therefore, I think it also plays a certain role. Still, the reconduction or the ablation of the right inferior vein with the RF Heliostar balloon is surprisingly straightforward as compared to what we initially observed with the cryo balloon, for instance. So therefore, that was a little interesting finding of our experience using the Heliostar device. The reconnection still, of course, if there was just one vein reconnected and it was the right inferior vein and it was a long delay, for instance, of course, we do re-isolate it, but I would always suspect there was also something different going on. I don't know, Devi, how you see that?
Yeah, and I mean, to me, this balloon is more of a, I don't know, has a customizable single shot in a sense, especially since you can, adjust the duration and the wattage on where as the lesions go. So I think to me it's more customizable, but I have not used it. So when I watch you do the case, I mean, you make everything look easy. So I think I think we have to wait and see. It'll be really challenging as an EP to have all this technology out there. And as we said before, I don't think we would be able to pick technologies based off whether it's paroxysmal or persistent. I think we have to have better indicators of which technology is going to be better for which patient. And I think it's long overdue we look in that direction.
What's interesting of this device compared to...
Sorry, I was going to ask exactly that, Julian. I was going to follow up with that and say, where do you think this device does fit in your practice? What's its role?
Yeah, very good question. Excellent question. The neat thing about this device is it also combines 3D mapping information with ablation. So we really have more information, and we discussed the role of potential, let's say, low voltage areas and the potential implication for subsequent anticoagulation strategies. It allows also, compared to the cryoballoon, which is maybe the big contestant or competitor in the field, different or ablation at different regions. And you can nicely select, for instance, at the interior part, you can select, you deselect posterior wall electrodes to customize the ablation. And therefore, this may allow also a high rate of durable lesions, because we know the gap patterns typically is not random. It is in thicker regions. It is in regions which are difficult to have a good and stable contact. So therefore, I see this as a potential advantage of the device. Also, the use of the 3D map per se, navigating the balloon without too much fluoroscopy throughout the atrium is also a potential advantage. And also the not necessary need in our routine. We typically use contrast to identify the PVs, but probably it is not required if you use the Heliostar. So there's some, if you subselect different patient groups, you find a good niche for the device, I believe.
Great. Any other comments about the RF balloon from you, Devi, before we move on?
No, I think Julian brought the most relevant points. I think the integration with the mapping system, showing contact, being able to select and deselect, I think those are going to be the things that keep this balloon apart from some of the other single shot balloon strategies.
Yeah, I have to say that my impression of it, having used it and done some of the early cases, was that it was very quick. The long-term results have been remarkably good. So it's a promising technology, and it's going to be very interesting to see how it fits into the other one-shot technology offers that we have. Finally, in the final part of this session, we'll be hearing from Roderick Tung and how his patient got on in the HD grid mapping in complex VT, new tools for improving mapping reliability and accuracy. And this was a case from the University of Arizona, Phoenix, US.